Blood pressure, pulse, and case studies.
But this one should have like local blood control or blood flow and microcirculation on it too.
Trying to find. Is it this one? It's open 10. Okay, so this is the order that I have them in. So week 7 was blood pressure, pulse, and case studies.
Yeah.
And then week 8 was a whole bunch of these questions about all that kind of
Week 8
stuff.
was when we had the lab practical, but we went over like microcirculation and blood flow that week. So I don't know if that would be incorporated on the lab practical or not, but I know it's final, like for the final.
Okay. I'm just trying to figure out heart sounds. I don't have like a set heart sound. Oh, maybe I had. Okay, our heart sounds we did week 6. Is this the lab heart sounds and case studies?
Yep.
That's the one.
Yes.
Okay.
Ours looks a little different, but that's the one.
Yeah, it should be almost identical, about the same, where it has all of the different doohickeys. Let's find the actual questions. Like these questions. My guess is that this is what he's referring to, the questions and case studies. All this stuff.
Yes.
Okay.
I believe so.
So let's do this. All of this is going to go. Case study for all of this here. Okay. I'm gonna kind of
put that file with the stuff that I have in it in the chat if anybody wants it.
Yeah, and I'll as I keep making this, once I finish with this, I'll post it as well. Okay, so starting off with heart sounds, all of these kind of questions, the murmurs that we're hearing during diastole versus systole. Easiest way to kind of get a grasp on this is to differentiate diastole versus from systole and kind of what is actually happening during those times. So as we've talked about 1,000 times, diastole versus systole. Systole is ventricular contraction. Diastole is ventricular relaxation. So if we think about these, during each of these, certain valves should be closed or other valves should be open. So we essentially have two big things that can go wrong. That we talk about murmurs and heart sounds and kind of that kind of stuff. So if we talk about things that can go wrong, we're essentially the ones that we test on are regurgitation or stenosis are the big ones that essentially we're going to focus on. Regurgitation is valve is supposed to be closed, but blood is flowing backwards. Stenosis, valve is supposed to be open, but blood is not able to get out. valve isn't open enough. So we think about this during ventricular relaxation, the ventricles are relaxing. As the ventricles relax, our AV valves are open. So during diastole, we can have any type of AV valve stenosis. Relaxation, AV valves are open. AV valve stenosis. And the semilunar valves are supposed to be closed. So that would give us semilunar valve regurgitation. Most of the answers that we talk about, we just talk about the left side of the heart because that tends to be the side that has more pathology, or like when pathology does show up, it starts typically in the left side of the heart. So that's where we kind of start, which is why most common, like you'll hear mitral stenosis or aortic regurgitation or aortic stenosis or mitral regurgitation. But when the mitral valve is open, you could have mitral stenosis or you could have tricuspid stenosis as well, or aortic regurgitation or pulmonary regurgitation. And those kind of super specifics will depend on the information that they give you on where in the heart you're listening to. The specific locations where you listen to the heart, which if you haven't heard this one, I think you already had it down here, Elizabeth, all of the locations. Aortic valve, yeah, all of these locations. The kind of the quick way to remember it is all politicians take money. All politicians take money. So aortic, pulmonary, Erb's point is in the middle between those, and then tricuspid and mitral. And so kind of playing with that, if you remember, it's always second intercostal space, third, fourth, fifth. So all politicians, skipping Erb's point, take money. So aortic, pulmonary, tricuspid, mitral. Erb's point is the extra one. So again, if you're hearing a noise during diastole, you're looking at either AV valve stenosis or one of the semilunar valves regurgitation. And wherever you're listening in the heart corresponds to that specific valve having issues. Systole is ventricular contraction. So we think here the let's just keep it consistent. The AV valves are closed. If they're not closed, we have AV valve regurgitation. And this opposite again, semilunar valves are open. Semilunar valve stenosis. In all reality, if you memorize one side, like, hey, this is what it is in diastole, you'll know what it is in systole. Let me actually... I don't want to add too much stuff. Okay. All those questions, and you can go wrong. That's stuff that we added. Now, case studies. All this is stuff. Case study number 1. He's going to pull almost these exact cases, just probably he's going to change the numbers around. That's what most of the teachers do. Or that's what all the physiology teachers have done in the past. They'll take these case studies. Let me know if somebody can have theirs pulled up. Let me know if these cases are the same as your guys' that you have, or if they're different. So if they're different, if somebody could post whatever you guys have in the chat, again, they should be similar, but we'll take a look. Okay, 32-year-old patient who had rheumatic fever as a child noticed a persistent tachycardia and lightheadedness. Upon examination, chest x-rays showed an enlarged left atrium. So immediately we're thinking, okay, what can cause an enlarged left atrium? Little note down here. If the muscle is enlarged, it is working harder / pushing more blood with each pump. Either there is regurgitation happening or there could be severe stenosis. Because in both of those cases, if we funnel backwards a whole bunch of blood, suddenly our heart has to pump more blood each time. If it's stenotic and it's super, super thin, then the heart's going to have to push and squeeze harder to get the blood out. Most commonly, when they talk about being enlarged, most commonly they talk about regurgitation. Most commonly, it can still be stenosis, but most commonly it's regurgitation. The ECG analysis showed atrial fibrillation. There was also mild pulmonary congestion. So if there's pulmonary congestion, that means that we know fluid has been backing up into the lungs. That means something after the lungs, something is going on where it's too much pressure, so fluid's backing up. Cardiac evaluation provided the following information. Cardiac output is 3.4 liters per minute. The blood pressure is 98/58. The left atrial pressure is 32 millimeters of mercury currently, and this is stuff that I've added into here. So less than 7 millimeters of mercury is normal for the left atria. So there's way too much pressure going on there. And a low frequency murmur is at the apex. Listening at the apex of the heart, can anybody tell me what valve we're listening to at the apex of the heart?
The mitral valve.
Yeah, so our mitral valve, which again, all fits because we have left atrial pressure is high. We have the mitral valve, we have a low frequency murmur, all this kind of stuff. Let's look at all of these questions. Is the left atrial pressure normal? Answer is no. Because what's normal? The 7 millimeters of mercury. What changes in the heart would cause an enlarged atrium and atrial fibrillation? This is cause of atrial fibrillation. Does anybody in their own words, can you describe fibrillation? What does fibrillation mean?
Like a flutter.
Yeah, it's kind of like a flutter. It's fibrillation is, you can kind of think of it like a spasm, where it's like it's not quite like it's trying to contract, but it's having difficulty, so it just kind of like contracts like this, like all over the place. So you said that flutter, that kind of I kind of imagine like a really, if you've ever seen those videos of somebody who gets a really bad muscle cramp in their calf and you can see it like ripple, it looks like an alien, looks creepy crazy. That's kind of what's happening with the heart, where essentially you're getting, it's trying to squeeze, but because there's so much muscle, essentially you get like a loop of the electricity, because by the time it's gotten through all of the muscle, which typically, there's that refractory period, that absolute refractory period. But essentially, it's so hypertrophic that it gets finished getting through all of the muscle, and the muscle at the beginning has reset enough that it can send another signal, and it kind of loops just like that. So, and what causes that? So increased pressure in the left atrium caused by mitral stenosis, which leads to left atrial hypertrophy. When we ask the question volume pressure overload, we're essentially asking where is the volume or the pressure too high or too high in this case because it's overload. So specifically, if it's volume, we're talking about regurgitation. If it's pressure, a little bit more stenosis. Based on the volume pressure overload, which valve is not functioning properly? And really, 90% of these questions, all you need to look at is this right here. This, where the murmur is located, is going to give you 90% of the time where you're supposed to be looking. Because realistically, I could have gone through all of this if I say, oh, there's a murmur at the apex of the heart. Immediately, that's the mitral valve. If I say there's a murmur at the second intercostal space to the right of the sternum, bam, right there to the right of the sternum, that is the aortic valve. So it's literally if you know those points, a lot of times this is going to give you your answer. Okay, so based on the information given above, would you predict stenosis or regurgitation? Now, I know what I had said earlier. A lot of times when you look at hypertrophy, you're more looking at regurgitation more often. Did he ever give you guys a graph that had all of the different sounds on it? What murmurs make what kind of sound? Did he ever give you guys that?
I'm pretty sure I saw it as I was going through trying to answer this, where it shows like what they look like, what the sounds will look like on the thing. Like
Yeah,
it's
it's at
like
the top
the
of ours.
diamond crescendo, like decrescendo, crescendo one, like all that.
Yeah, that kind of stuff. Let me see if I can. I have one. I know amongst all of my stuff. There, let me see if I can find it relatively quickly. Actually, I have it. It should be within part of the lab. It gives you kind of the sounds. Most commonly, yeah, like the diamond shape, the crescendo, decrescendo, loud to harsh, blowing murmur, these kind of these kind of keywords. All right, give me 1 sec. Okay. If you're able to tonight, I would do is, or if everybody as a group wants to do this, make flashcards just like with these specific instruction, like these specific characteristics, because these kind of things, this is how they'll describe each of them. So regurgitation, and you can make links between these. Regurgitation, it's a blowing type murmur. Regurgitation, blowing type murmur. Yeah. Blowing type murmurs are our regurgitation. The stenosis, for mitral stenosis, it's a rumble. You get what's called a thrill. So these kind of keywords, these will come up in your example, in this exam, and then also be on your final. So, and in the long run, a lot of this stuff, these kind of sounds, when you get to trimester 4 and you do what's that class? Physical diagnosis, Phys I believe it is. You have to know what all of those sound like. So that's a future thing. But if you know the sounds now, we're good. Okay. Continuing, based on the information, stenosis regurgitation, because it's at the apex, it's the low frequency murmur. The low frequency murmur that corresponds to stenosis. And then would this murmur occur during diastole or systole? If it's mitral stenosis, it's during diastole, specifically ventricular diastole, because that is when the AV valves are supposed to be open, so it's not open enough. Describing this murmur, all of these guys, that low rumbling, the low pitch, the thrill, the decrescendo, all of those kind of words are describing it. What are some of the physiological causes of tachycardia, lightheadedness, and mild pulmonary congestion? It's like more of an extra type of question, but whatever, we'll answer it. So basically, as we know, brain needs oxygen. When brain's not getting oxygen, it makes the heart beat faster because the brain wants oxygen. That's basically as deep as it goes. So because the brain needs oxygen, it speeds up the heart rate. Because the brain is low on oxygen, you get lightheaded. Because you have that increased pressure in the in the left atria. The pressure is less in the lungs, so everything flows from high pressure to low pressure. Everything's going to go backwards. It's going to go back towards the lungs because the lungs have lower pressure than the mitral valve does currently. Any questions about the stuff that we've covered so far? Okay. Sure. If this murmur had been described as a high frequency, blowing type murmur, what would have been your diagnosis? When you see the word blowing, that's our key word. Immediately we think regurgitation. It would be mitral regurgitation. What is the oscillatory site for this murmur? Again, I wrote apex, but a better answer would be the left fifth intercostal space mid clavicular line. You'll get a bunch of questions just like, where do you listen to this valve? Where do you listen to that valve? Where is this thing located? So you'll have a handful of questions just like that. And when would you hear this murmur? Again, if this is specifically more, I think that's how it's actually. The mitral regurgitation, you're going to hear during systole because the valve is supposed to be closed during systole. If it's open, then that's where you're getting regurgitation. Case study 2. During a routine physical palpation of the patient's chest wall revealed a thrill. Did Dr. Tate or anybody ever go over what the hell a thrill is?
No, but I was talking to one of my Try 8 friends, and she was explaining it. She basically said it basically just feels like a vibration, like a palpable vibration.
Exactly. So when you're checking for a thrill, you place your fingers kind of in the intercostal space, and you'll almost feel like a bzz, like a vibration, but it's like this is what you'd feel like if you're putting your hand on somebody's chest. This is their chest wall. You'd almost feel kind of like the skin underneath is vibrating. That's what a thrill is. And there are two conditions that are going to cause that thrill. They are both stenosis. So here's what we can associate. Word association. Thrill is associated with stenosis. So as soon as you see the word thrill or trill, you can take off the H. It means the same thing, but that is stenosis right away, is what you think about. Which murmur with an associated thrill would be auscultated at the apex? Now, I want to double check because it looked like something in the lab manual might have been. Okay, yeah, we're good. So again, thrill, we're talking about stenosis. So we're talking about the mitral stenosis. Side note, if you heard a blowing murmur at the apex, that could be mitral or aortic regurgitation. This is like a weird kind of extra thing. This is why you'll just double check all of the rest of the information. If it mentions anything specific or mentions anything else about hearing something on that second intercostal space on the right side, or if it mentions anything else specific to mitral versus aortic valve, look at the rest of the information to determine that. And get as much practice and stuff in as we can. Okay, where is the oscillatory site for the other murmur with an associated thrill? So if we think mitral stenosis is the one, the other is the aortic stenosis. Again, second intercostal space to the right of the sternum. You want to get super specific. It's technically 1 to 2 inches to the right of the sternum. I don't think they ever get that specific, but it's been a while since I've taken physiology and not with this specific teacher. So Describing this is loud to harsh. It's crescendo, decrescendo. When would it occur in the cardiac cycle? Again, we want to stop. We want to think. The other member with the associated thrill, it's the aortic stenosis. When is the aorta supposed to be open? During systole. A lot of these questions, if you remember, if you've watched any of my heart videos material, if you were here for live sessions, I told everybody 1,000 times that you absolutely need to know that stupid little cardiac cycle chart. You know which one I'm talking about? This looking little guy like this, right? Where you have with the isovolumetric contraction, isovolumetric relaxation, filling, and ejection, all this kind of stuff, and like where valves are open, where valves are closed. This is all coming back to that. If you know this like the back of your hand, this will be a lot easier. Okay. Case 3. During a routine physical exam, you record the following data. Heart rate, 95 beats per minute. As you read these questions, go through and check in your head, are these normal or abnormal? 95 beats per minute. Normal is 60 to 100. We're good. ECG findings. The PR interval is 0.18 seconds. Is that normal or abnormal? Who remembers their PR intervals?
It's normal.
Yeah, normal. What's normal?
0.12 to 20, right?
Yeah, 0.12 to 0.2. Yeah. The QRS complex is 0.11 seconds. Is that normal or abnormal?
A little high.
A little high. I think, does he give you 0.08 to 0.1 or 0.06 to 0.1?
108.
Okay, 0.08. So immediately in our test, we're like, okay, that looks a little bit. We'll check with the rest of it. QRS voltage, 2.6 millivolts. Is that normal or abnormal?
Really high.
That's definitely high. As soon as we see it's high, what do we think? What does a high QRS voltage tell us about the ventricles?
Something's wrong with the ventricle.
What specifically is wrong with it? Big QRS voltage means more electricity, which means more muscle. So we have hypertrophy. So we have ventricular hypertrophy is going on. So we stop, we think, okay, ventricular hypertrophy, what could be causing that? We start to think, okay, we're thinking aortic regurgitation, potentially aortic stenosis. Just depends on what other information we get. The T wave is normal. ST segment is 0.05 millivolts. When does our ST segment become abnormal? What are we looking for?
Is it over 1.5?
Over 1. If there's
Over 1.
1 up or down. Actually, 0.1 technically. It's 0.1 millivolts. One small cube up or down is when we start worrying about ST segments. The mean electrical axis is negative 24 degrees. Is that normal or abnormal?
Abnormal.
Abnormal. What's our normal mean electrical axis?
0 to 90.
Yeah, 0 to 90. I'll let you know, in the real world and for boards, technically, it's negative 30 to 90, but that's, real
To
world
account
versus
for,
school.
yeah, if their heart's tilted at all.
Exactly. The patient was sent to a cardiologist, and his reported findings shows that the cardiac output is 3.9 liters per minute. Is that normal or abnormal? I don't know if he gives you the specific normal. It's typically anywhere from between 4 to 8. 4 to 8 is normal. But there's a lot of variability with that. So 3.9, close enough. Left ventricular pressure is 195 millimeters of mercury. That is way too high. Normal should be at maximum about 120, or just over 120 diastolic or systolic pressure. And there is a diastolic murmur. Diastolic murmur. What murmurs can be heard during diastole? Where would we have regurgitation? Where would we have stenosis?
Mitral stenosis, aortic regurgitation.
Good. That's what those are our two choices that we're looking at. If you had to guess right now, what would your guess be? Mitral stenosis or aortic regurgitation? Which of these two would cause hypertrophy of the ventricle?
Mitral stenosis.
So mitral stenosis, think of everything kind of works backwards. So if there's an issue with the mitral valve, it's going to affect the atria. If there's an issue with the ventricle, it'll work backwards to the atria. If there's an issue with aortic valve, it's going to affect the ventricle. So always look backwards from where the issue is. So in this case, we're going to be looking aortic regurgitation because we have ventricular hypertrophy. So because the ventricle is hypertrophied, so its muscle mass is increased, it's working way harder. So we look what's immediately after the thing that's the issue, the aortic valve. Does that thought process make sense as far as why we would kind of go that route?
Yes.
Okay. That's the way I want you to be thinking about these kind of problems. So where is the volume or pressure overload? So again, when we talk about overload, right? We're looking, okay, especially with overload, means that it's working way harder than it's supposed to. So we're getting hypertrophy. So where's the hypertrophy located? Inside the left ventricle in this case. And we know that because we have increased QRS, we have a high QRS interval, and a leftwards deviated. I'm actually going to just leave this as 0 so it doesn't confuse anybody looking back at this. So negative 24 is leftwards deviation. Left deviation, whenever we have deviation, think back. Why do we get deviations in the mean electrical axis? What are the three things that cause a mean electrical axis deviation? Making you guys think a little bit.
Hypertrophy, injury, and I don't remember the third one.
Bundle branch block.
Hypertrophy, injury, bundle branch block. Two of them cause the same direction. One causes the opposite direction. Do we remember which is which?
Injuries opposite.
Yeah. Good. I'm going to throw as much of like these reminder things as I can into here because this kind of stuff may pop up as well as you're taking this exam. Okay, based on that volume pressure overload, which valve is not functioning properly? Aortic valve, what ECG or other information to use to come to that conclusion? So we have a long QRS, we have a high R wave, QRS wave. The mean electrical axis is deviated to negative 24 degrees. And then would you suspect stenosis or regurgitation? We already gave this answer. We said regurgitation because it is a diastolic murmur. And if you remember, where would we listen for This is where it gets a little bit weird because you technically would hear this. What site would for this? Remember, you would technically hear it at the apex of the heart, or you could hear it at the right second intercostal space. So either this will be your number one answer. If it's there, this is your number two answer if apex of the heart is not there. Most of the time, your number one answer will be like the one that they give. So if you don't see apex of the heart there and this is what you think it is, go back and double check your work to make sure that you're looking at the correct murmur and that you got every part up to that point correct. Okay, if this murmur has been described as a systolic murmur, what would be your diagnosis? Systolic murmur, what would be your diagnosis? With all of the same findings and everything, you'd have to go with aortic stenosis. Aortic stenosis is where the auscultatory site be, that second intercostal space to the right of the sternum. How would you describe the murmur? All of these extra fun stuff. And like I said, he's more than likely going to give you almost these exact same questions because I don't think I should say this in the recording, but I'm going to anyways. From what I've heard, he's a little checked out, so he's probably not planning on writing a whole bunch of new questions. So, yeah. Okay. Case study 4, a patient has a ventricular septal defect. Who can tell me what a ventricular septal defect is? What does that mean?
There's a hole in between the ventricles causing backflow.
Perfect. So what data would help you with this diagnosis? Looking at the direction of blood flow, murmur description, it's a harsh blowing type. It is what is called pansystolic, very good vocab word for you to know. It's heard all throughout systole and diastole because in both cases it's running through. I don't know if he went into this much detail, but along that same note, technically, if it's a really small one, you'll only hear it in systole. But if it's big, it's pansystolic. Most of the time, they ask about pansystolic because it's the more fun word. The auscultatory site, third or the fourth intercostal space on the left side. The third space is again that Erb's point. Yeah. Okay. The volume pressure overload. Volume overload in the right ventricle, pressure overload. Volume overload in the right. Yeah, it's both. Because the left ventricle has higher pressure than the right ventricle. Because the right ventricle is going to the lungs, so it has pretty low pressure already. So the blood is mostly going from the left ventricle, pushing back towards the right ventricle. What's the left there is just kind of a couple little extra tidbits. So, okay. That took a little while, but a lot of the rest of these questions now are essentially going to be continuation stuff. So, how is the stethoscope used to detect heart sounds? There's two different sides to the. There's the bell and the diaphragm. Bell is going to be used. just right down here. These, like the way that he has these worded, like this is like exact questions he's going to be asking. So what sounds with the diaphragm? Let's see this. Bell is the smaller or curved part. Diaphragm is the bigger / flat side. What sounds would the diaphragm be best employed to hear? Those medium to high pitched sounds. Yep, S1 and S2. What sounds would the bell be best employed to hear? Those lower pitch sounds, S3 and S4. You also pull up. Good. I'm going to double check everything that I confirmed. It's like, hey, we're good. I'm going to put back to black just so that we, the oscillatory sites, which ones to her, which side? Second across the second, third, fourth, and fifth mid clavicular line. A lot of this is a lot more straightforward than you think. Just remember that little dance. All politicians take money. There was one about a monkey as well. I don't remember what the monkey one was though. I will say it also helps to okay. Can you relate each stage of the cardiac cycle to the heart sounds? Does he still use lub dub? Is that how he taught you guys lub dub?
Yeah.
Okay. There was a recent thing where they started like spazzing out about using lub dub, but okay, if he uses it as well, that's good. So cardiac cycle to the heart sounds. Let's see if they have. Each stage, so S1. All this looks good. So occurs during the beginning of systole. AV valves are, I like to say, snap shut. The AV valves close. S2, the dub, it occurs during diastole. The semilunar valves close. So always remember all of the different names. Mitral, aka left AV valve, aka bicuspid valve. Sometimes they'll throw the different names. Tricuspid, aka right AV valve. Semilunar valves close. It occurs during diastole. We have the pulmonary and aortic valves. S3 occurs during early diastole. Can anybody tell me what actually is the S3 heart sound? What causes the S3 heart sound?
It's the blood hitting the bottom of the ventricle,
Good.
like just splatting on the bottom of it.
Okay, so it's blood from the atria hitting we use the term non-compliant ventricle. Remember when we talked about compliance, we kind of talked about how much give, like how well it was able to accept the blood. So it's blood from the atria hitting a non-compliant ventricle during the passive filling phase. And remember that the passive phase is 75% of filling. Big one that's always asked, that is normal in children. It's always on the exam. S4, it's literally caused by the same. So it's blood from the atria hitting a non-compliant ventricle during the active filling phase. When I say active versus passive filling phase, what does that mean?
Passive means it's like just the pressure's like the pressure gradient's going to the ventricle, but then active means the actually contracting, like the atria is actually contracting.
Yeah.
Yeah.
The passive, the atria are relaxed. Active equals atria are contracting. Occurs during late diastole. It is rare. Always pathological. It always means that there's something going on. Okay. Do you know what stenosis and regurgitation means? Regurgitation, backflow that occurs when valves do not close completely. Good. Stenosis, blood flow restriction due to valve openings being too small. Most often due to calcification of the valves. It can do to like calcification, due to it's a calcification or hardening of the valves. A word that you might hear is that the valve opening is not patent. If you don't hear that terminology used in this class, you'll hear it in the future. My recommendation is this stuff, like the Mr. Ask Miss Ard stuff. I don't feel like it's not great to learn it this way now, because boards is going to ask you the questions like a little bit deeper, as well as your future courses are going to ask you the questions a little bit deeper than just like, is it systole, is it diastole? My recommendation is, if you need to learn it this way for this exam, that's fine. Just keep in mind understanding that cardiac cycle, this whole process, this whole thing. That looks really weird. Do like that. Understanding this is going to help you a ton, understanding all of this, like when valves are open, when valves are closed, what valve is open, what valve is closed, and kind of what's going on with that. But whatever you want to do for this exam. What's up?
So when I was talking to my friend about this, she said something about, and I think she showed it to me in the Irene Gold thing. The arms and parts. Is that a better way to learn that?
You said arms and parts.
Yeah.
That's another way of kind of remembering it. Again, let me see. I should have that here. I don't remember that one. That's why I was saying, like, I personally didn't learn it this way because yeah, so this is like arms and parts occurs during diastole. So arms and parts. So aortic regurgitation, mitral stenosis, pulmonary regurgitation, tricuspid stenosis. Or you could just remember during diastole, semilunar regurgitation, AV stenosis, and it's opposite for systole. Personally, I think it's better to remember that way because it's less to remember. So you could write AV stenosis and semilunar regurgitation equals diastole, AV regurgitation, and semilunar stenosis equals systole. However you want to remember it. Again, like I said, like for sure I know when I took Phys and everyone else is taking Phys beforehand, like my understanding is they only ask you questions about the left side of the heart. Like once in a blue moon, they'll have one question about the right side of the heart. But the right side of the heart just doesn't get tested like the left side does. So yeah. However, whichever way you want to remember it, like it's not as long as you remember it. Here are all of these guys. All of this is, I'm assuming you just took all of this from the straight from the lab manual. Breaking it down and like finding the commonalities. So what I would do, like regurgitation are blowing and high pitched. So you could even insert blowing and high pitched equals regurgitation. And then the other connections, let's see, do aortic regurgitation and mitral stenosis heard at apex. Crescendo, decrescendo, that's the only one. So go those, those keywords that are going to help you. So aortic stenosis equals the crescendo, decrescendo, all this kind of stuff. With any time you have regurgitation, you're going to have hypertrophy, all that kind of stuff. I mean, all of these are going to, the more that you can kind of pair this stuff together, easier can be, because there's no shot you're going to be able to, you're going to memorize each and every single one of these things. So just generalize, and there's always a handful of questions that they pick literally just like this. Like you have they'll give you like aortic regurgitation, so it's a semilunar regurgitation heard during diastole. So you have a diastolic murmur that is blowing with and high pitched, heard over the apex. Which of the following is the correct choice? And like that's how he'll literally give you questions just like that. So categorize each heart murmur as systolic or diastolic. Again, all this kind of stuff. Why each is categorized as such when the valves are supposed to be open versus shut. Can you describe each heart sound? When would you hear each sound? Again, all this stuff is above. Yep. Volume pressure overload and what it means. Does volume pressure overload make sense to everybody, or is that something you want me to dive more into?
Yeah, could you explain it a little more? That's part of the reason I didn't put anything there, because I was like, I don't really get it.
So with volume pressure overload, with all the pathologies, they are caused either by a volume overload or a pressure overload. Overload equals more blood volume or more pressure in a specific chamber, which is causing the issues. So if we look at something like aortic regurgitation, right? With aortic regurgitation, we get a backflow of blood. So we have a lot more volume of blood in the left ventricle at once than we usually would. So the volume pressure overload is in the left ventricle. It's like telling us which chamber of the heart is essentially getting the raw end of the deal. Does that make sense? Or do you want me to keep going?
No, I think that makes sense. How do you know, like, if it's volume or pressure? Like,
They go hand in hand. Like, if you put more volume into the same amount of space, pressure goes up. So I would say, with regurgitation, you get an overload of volume and pressure. With stenosis, you get an overload of pressure. Does that make sense?
yes.
They call it the volume pressure overload because it's one or the other or both. So okay. What other effects can the disorders have? So, result in pulmonary edema, increases the blood flow. Yeah. So what all that you've written is correct. Big idea, just like main idea equals if a valve or chamber is jacked up, everything behind it is going to have problems. Kind of like, do you guys remember when we talked about left-sided heart failure? Or you guys remember when we talked about what is the main cause of right-sided heart failure? What's the one thing that causes right-sided heart failure more than anything else? Left-sided heart failure. Did I mention that to you guys, or did he mention that to you guys? Does that sound familiar at all?
It makes sense.
I feel like I remember you mentioning it briefly.
Yeah, this is a big boards concept. Basically, just look behind. So, like if the aortic valve is jacked up, something is going to be happening in the left ventricle. If something is jacked up with the left ventricle, eventually it'll bleed backwards. Because if we drastically let's say we have aortic stenosis. With aortic stenosis, right, the left ventricle is going to have to work harder. We're not going to get as much cardiac output going. Left ventricle keeps working harder, working harder, working harder. It's going to hypertrophy, it's going to tire out, and that can actually bleed backwards into the mitral valve, eventually into the lungs. And then once the lungs are involved, then it involves the right side of the heart, and it works its way back. You're not going to get asked questions like that, like that deep. Just think, we have problems, but the test is going to focus on whatever is immediately before what is messed up. So, for example, aortic valve issue equals look at left ventricle. Mitral valve issue equals look at left atria, maybe look at lungs, because the lungs are dumping into that atria. Issue, yeah, and that's as far as I'll go, because again, they don't really look at the right side of the heart. So all of this, does all of that make sense? This is the big idea. If you understand this big idea, and if you understand, like, hey, we're going, from pressure system to pressure system, high pressure to low pressure, consistently. And if we mess up our pressure, we get over, or we have too much pressure in one spot, it's going to cause things to go the wrong way. And that's what causes all of the other issues. Like if you have edema and swelling in your legs, often that's a sign of right-sided heart failure, because the blood and everything gets backed up, like more towards like the liver and stuff, and you get more pressure in your venous system, so you're not picking up as much fluid to bring it back as you should be. At one point there was a question, I think, that asked about swelling in the legs. I don't know if he asks that question or not, but now you know it. Okay. Everybody good with lab 9? Everybody good with week 9?
Yes.
Okay. If you have any questions at all, you can throw them in the chat or just speak directly to me. Okay. Blood pressure and pulse lab. The blood pressure technique won't be assessed in the lab exam, rather understanding of this technique will be assessed. So the method for measuring blood pressure through a sphygmomanometer and how would a stethoscope be useful in recording the blood pressure. So you're going to want to know the specific steps. Why does it do this to me? I just want there. So the method for blood pressure. So there's several steps. So step by step, put the cuff on. Does he say it's, correct me if he has something different. This is the way that I've learned it and done it. It's 1 inch above the cubital fossa, I think it's called, right? What's the front of your elbow called?
Cubital fossa.
Yeah. With the artery arrow lined up on which artery? The brachial artery. The number of people who get confused with the radial artery. It's a lot. Okay. With the artery air lined up with the brachial artery, you palpate the radial artery. At the lateral side of the wrist, palpating right in, right in there. Inflate the cuff until you no longer feel the radial pulse. Deflate the cuff. And I think you're technically supposed to rest for however many minutes, but that's like a super technical, you won't actually do that in real life kind of thing. Usually not asked. Inflate the cuff. How many millimeters of mercury above the pulse ablation? That's what it's called, right? Pulse ablation. All the technical terms. Pulse obliteration, that's what it's called. Pulse obliteration. This is oftentimes a question on exams. Inflate the cuff too long and feel the radial pulse. This is called pulse obliteration pressure. The pressure at which you no longer feel it. And so you want to inflate the cuff 20 milliliters of mercury above the pulse obliteration pressure. Deflate the cuff at a rate of 2 to 4 millimeters of mercury per second while listening with the diaphragm of the stethoscope at the brachial artery. Listen for the rot cough sounds to start. This is your systolic pressure. Listen for the crack cough sounds. Stop. This is your diastolic pressure. Always record blood pressure with even numbers. Any questions there? Cuff should be at heart level. Patient's feet flat on the floor. Patient should not speak. Taking sure. I think those are all the things that they like to ask questions about. Did I write anything down in all of that? That is either new information or is different than what you've learned?
Nope.
Okay. How does stethoscope useful in recording the blood pressure? It's the crack cough sounds. First systolic, good. Arteries and press, good. When is systolic blood pressure recorded? Again, that first crack cough sound. Maximum blood pressure when the ventricles contract during systole. Peak vertebrae, what happens to blood flow? Blood flow zooms through the arteries, the cuff pressure drops below systolic pressure, affecting the external pressure, already temporarily including it. Yep. When is diastolic blood pressure recorded? Again, this is the same. Did he ever go into auscultatory gap?
That does not sound familiar.
Okay. I'm going to tell you about it just in case, because this was tested when I was in physiology. So the reason we go 20 millimeters of mercury above the pulse obliteration point is because there may be a gap. This is also why you continue to listen with the stethoscope all the way down below, all the way down as you deflate. Some people will have a gap, so randomly, so crock cough sounds, you'll hear crock cough sounds, the kunk, 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 and then all of a sudden they go away for 5 to 15 millimeters of mercury. And then all of a sudden they start again, kunk, 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 kunk. Some people have it. I don't know why it happens, but it's just, this is why auscultatory gap is why we go the 20 millimeters of mercury above, as well as why we listen all the way through. We don't just, as soon as they stop, we don't deflate. We listen all the way through until you get down to, to like 50 millimeters of mercury, where it's reasonable that, their blood pressure wouldn't be that low. So sometimes that becomes a question. So the definition of it, this is just a silent gap in between Karat cough sounds that can mess up your reading. To your blood pressure question, the peripheral pulse curve, all this stuff. Do you guys know what causes the dichrotic notch? Why is that a thing?
Gravity.
Gravity, yes, because when our heart squeezes blood out, it has to go up the arch of the aorta and then down. So blood is still there and going up, and then as soon as the valve snaps shut, it kind of like blump drops down thanks to gravity. Cardiac function to the pulse curve, all this stuff. It's real quick. Was it related to the cardiac cycle? Yep, you have ventricular relaxation. The cardiac cycle is related to pulse pressure as well as it's the big one, pulse pressure. Relates to cardiac cycle because it gives us our pulse pressure. Peripheral pulse curve, a dichrotic notch, all that fun stuff. Relate cardiac function to the pulse curve. Five, six, okay. Compliance, that's all fine. I'm not sure what this is actually asking, be able to relate cardiac function to the pulse curve. I wonder if it's talking about, like, I guess is that there's a little chart.
Yeah, I couldn't find that in the the lab manual anywhere, so I just Googled it.
It's like
That's
there was something like this. There was a couple specific ones, like what it looked like with regurgitation and what it looked like with other stuff. You know, remember? So with regurgitation, cardiac function to the pulse curve. So like normal pulse should be consistent. And then we have, this is showing us, you know, the difference in pressures. So pressures should be like that normal-ish values, you know, somewhere like that 120 over 80, kind of within that area. If pulse pressure is huge, think that stroke volume is way up. Could be due to regurgitation. This is mostly when you'll see it. Like you'll typically see like this kind of big, the large and bounding pulses. This is what aortic regurgitation. So this is what normal looks like. This is a normal. The further out you get, so the further away from the heart you get, the weaker the pulse. So like if you're palpating the pulse, if you palpate the carotid, very, very strong pulse. It's easy to feel. Palpate, you know, the axillary pulse. It's little bit, it's not quite as strong as the carotid. You can palpate the brachial pulse, and you can palpate the radial pulse. Same thing, like as you go down the body, you can palpate like the femoral pulse, the posterior tibial pulse, and then the dorsal pedis, which is on the top of your foot pulse. And so it's just saying the further you get from the heart, the weaker the pulse is because you're not having like that direct push from the blood flow. So if you have issues right at the heart and you're looking at the pulse curve right at the heart, like large and bounding, this is the one you'll mostly see. That's like aortic regurgitation. Small and weak pulses, would you be dealing with like stenosis or something else blocking some of the vessels? So yeah, but there is a direct relationship to stroke volume. So, you know, if you look at the pulse curve, bigger pulse curve, you have increased stroke volume. Inverse relationship to compliance. So that means like less compliant vessels equals like a higher pulse pressure. You'll see the pulse curve jump higher because it's going to be affecting blood pressure. The significance of pulse curve events to the cardiac events, What is a dichotic notch caused by? Yeah, blood that falls back toward the aortic valve because it is in the ascending aorta and gravity acts on it, pulling it back down. What is the slow decline in the peripheral pulse due to? So this pulse, the slow decline to blood traveling through all of the vessels, cross-sectional area increases, blood slows down. Remember all that talk about cross-sectional area and how the further you get away from it, why doesn't the end value reflect left ventricular pressure? Again, because it's had to travel. Yeah. The factors that impact the aortic pulse curve: stroke volume, vascular compliance, pathology, think stenosis, or regurgitation. The blood pressure case studies, all the fun stuff. Okay, is this where you've gotten to, or you kind of all that's extra? Do you guys want to go back over the blood pressure case studies?
No, I didn't put them in there just because I was actually going to ask you if you would go over them, and then you did. So
Okay. Blood pressure case studies. I think it should be in this one. Okay, do you want me to solve through each of them with you, or do you want me to just show you and just walk through them?
press walk through them, I guess.
Just walk through? Okay. So we have all of our big old equation sheets, so those will be he said he'll give you the equations.
Yeah, he said he would let us have them.
Good. Okay. Case one. You'll notice like a lot of these cases, the numbers will change, or he'll literally have like these cases like verbatim for your test. 43-year-old man and his father, who's 80, both have heart rates of 60 beats per minute, cardiac outputs of 4.8 liters per minute. The son had a peripheral resistance of 20 millimeters of mercury per liter per minute, and the father's was 30. Both of their aortas contain 40 milliliters of blood at a pressure of 100 millimeters of mercury. So the 10 milliliters of blood is added to the aortas of the father and the son. The son's pressure is increased to 105, and the father's pressure increased to 110. Which aorta was the most compliant? So we look at our compliance, change in volume over change in pressure. So the son had 10 milliliters over 5 change in pressure, and that gives us our compliance, which is in milliliters per milliliters per millimeter of mercury. So compliance, we want compliance to be high. So as we can see, if you add volume, and this is also what you would expect. You'd expect somebody who's younger to have higher compliance in general, because their vessels are younger, their vessels are not as worn and torn and weathered. What effect would the difference in compliance have on the mean arterial pressure? Again, compliance is how much give the vessels have. So when vessels have more give, when you put blood and stuff, you change the amount of volume in them, the amount of the pressure overall changes, or is not as drastic. The pressure changes are not as drastic with the changes in volume. So if we have an increased compliance, our mean arterial pressure is lower. If we get lower compliance as we get older, our mean arterial pressure goes up. So again, just a lot of this is just going to be the straight calculations of mean arterial pressure calculations. So we look mean arterial pressure. Our three different ways to write it is our cardiac output times the total peripheral resistance, and it gives us our numbers. How does the pressure difference affect blood flow, which is Q? So the son's blood flow versus the father's blood flow. Flow equals the change in pressure over resistance. And if we actually look at this when we do the calculation, so for the son, his change in pressure was 5 over the resistance, which was 20, versus the dad, who changed 10 over 30. It actually looks like I didn't solve this one appropriately. But yeah, we do the math. 5 over 20, what that's 0.25. 10 over 30, that's 0.33. So yeah. So you get more flow with more pressure. Probably just gonna leave that there, but it's fine. Next part, the father and son both have a stroke volume of 80 milliliters. Would there be a difference in pulse pressure? We calculate that. We have more equations. This is when you start kind of getting into stuff. If he gives you, is this equation sheet, was this already provided for you in this thing, or did you put all of this in, Elizabeth?
That one was in there. He has also posted another one that has that and then the spirometry stuff in there as well.
Okay, good. Okay, so he gives you all the equations for the spirometry too.
Yes.
Sick. Free then. Yeah, with all of these equations, if you understand the concepts behind them, like the math part of these, every single math question should be just completely free points. As long as, you look at your equations and then plug in the correct values for each of those. So, some of the extra tidbits, a lot of this won't be asked, but so you take x-rays, the father's aorta was clearly visible, but the son's was not. How is this related to the differences in compliance? As we age, we can get calcification of our vessels. Calcification of the vessels shows up on x-ray. And when you add calcium to stuff, it gets harder and it's not going to be as compliant. The father begins an exercise routine to try to prevent further damage in the circulation. How does sympathetic input alter blood flow during exercise? We've seen this is all this. So the sympathetic system will cause, increased heart rate, more cardiac output, more venous return, more stroke volume, all that kind of stuff. You can't, especially with age, you can't uncalcify vessels really. Once they're calcified, you can't change that. So he's not going to be able to really change his compliance of his vessels, but he can improve his overall cardiovascular health and the way that his heart, moves the blood and everything. So, next case, again, just his blood pressure 162/74, vascular compliance was 0.3. What is the pulse pressure for this individual? If we look at 0.3, 0.3 is very low. That means his compliance is bad. So what do we expect as far as pressure and everything? We expect, him to have higher blood pressure, which he does, especially systolic blood pressure. This is considered like 140s, 150s is considered normal in 55, 60 plus year olds. Okay. What is the pulse pressure? Look at our equation sheet. Pulse pressure, systolic minus diastolic, 86. The mean arterial pressure, literally just plug in pulse pressure, plug in diastolic, add it all up. There it is. Low compliance leads to a higher pulse pressure because low compliance means we have higher systolic blood pressure. Do you want me to keep going through these, or do you feel like they're a little more straightforward?
I think because he's going to give us the equations that it'll be fairly straightforward.
Yeah, with the equations, like, you should be good. Let me just read through this real quick and see if there's anything else that we would want. Like, here's one. Auscultation of the heart reveals a murmur starting at S1 with S1 and is heard loudest at the second intercostal space. Starting with S1, we need to stop. We think, okay, the S1 heart sound, what is that? That's the closing of the AV valves. So this is a systolic murmur. Second intercostal space, just to the right of the sternum. That's the aortic valve. That's going to be aortic stenosis. So that's, essentially what he'll do, he'll give you like this whole question, this whole information, and the actual question at the end will be one of these questions. So all this stuff should be stuff, again, I think this one is like this is claudication. So he seized his position because of pain in the calf muscles of both legs. When he walked moderate distances, especially uphill, the pain subsided when he rested. The pain had been insidious in onset and recently occurred more frequently even after shorter walks. The patient had smoked 3 packs of cigarettes a day for the past 34 years. Smoking causes vasoconstriction, especially in the peripheral vessels. X-ray exams revealed arterial calcification of lower leg arteries and significant obstruction of the arteries above the knees. If you ever see the word, which you will in the future, but on this test specifically, if you see the word claudication, vascular claudication, what this means is that vessels are constricted or too small to provide enough blood to the area. This case is like textbook vascular claudication. You start moving, somebody who's a smoker, peripheral vessels give vasoconstriction. This is called peripheral artery disease. You start moving, your muscles need more oxygen to work because your vessels are constricted, as well as, like calcified, other issues from age and from smoking and from all that stuff, inflammation. You get your legs hurt real bad. So Has he ever mentioned that word, claudication?
Not that I remember.
Okay. I'm going to give you another one like it, neurogenic claudication. Nerves are being compressed in the low back, most commonly. These two can present very similar. The big difference, vascular claudication, subsides with rest, subsides when he rests. And then think walking uphill. When you walk uphill, you kind of lean forward, right? Neurogenic claudication, goes away when you lean forward. I doubt you'll get tested on this if you haven't heard of it before, but like it's not unheard of that they'll throw questions in there that you haven't seen before. Okay. Those are those big deals with all those cases. And that's pretty much all of week 10. Okay. Much more in this one stuff as well. Do you guys have this test tomorrow or Wednesday?
I have mine tomorrow at 10 a.m.
Mine's at 1
Okay.
or 3. Sorry, not at 1.
At 3. Okay. My time, like the time that I have, like I need to go put my son in bed and everything. So I think what we're gonna do, end here. I'm gonna go do what I have to do. If it's not too late, I'll send out another message, and if my wife lets me, I'll come back and jump on, and we can get through a little bit more, like through week 11, week 12, to hopefully be prepped for, or maybe we'll jump to week 13, because that one isn't fully filled out yet. Does that sound okay?
Yeah, if nothing else, Drake, will you? There's a couple in there, and you'll see them. I just put like, huh, or like question marks. So if you don't get to hop back on, will you just send me like explanations on those?
Yeah, I'll try, and if I can, I'll look through it. Would it be easier? It might be easier. Do you want me to see if I can hop back on and we can go through it, or do you want me to just look over it and then add whatever I think I should add and then send it out to you guys? Which would you prefer?
I mean, if you can hop back on, that would be super helpful for me. But either way.
Okay.
I
I'll
feel
send
the
that.
same way.
Okay, I'll send out a message to the group me once I finish putting him to bed and doing what I have to do, and I will let you all know. Okay?
Thanks, sir.
Thank you.
I'll reach out soon.